Hi everyone. Thank you all for coming to our global COVID-19 vaccine equity workshop. We are super excited to learn with you all. My name is Sonia Nair, and I'm one of the organizers for this event.
Hi everyone, my name is Ikenna Medina. I'm another organizer for this event. First off, we'd like to thank our amazing speakers for making the time to come and speak and learn with us. This evening, we have Dr. Saad Omer, who is a director of the Yale Global Health Institute and specializes in global health, vaccinology, and infectious disease. We also have Dr. Ruth Faden, founder of the Berman Institute of Bioethics at Johns Hopkins University, who specializes in global health and structural justice theory. And we also have Dr. Jason Schwartz, global assistant professor of health policy management at the Yale School of Public Health, and he specializes in vaccine and vaccine policy.
Okay, wonderful. Thank you all for being here, and we'll get started. And if any of the audience members have additional questions, you should have like a Q&A feature at the bottom of your screen, and we'll get to them eventually. So our first question for you all, I guess, we wanted to kick it off by asking about the history of vaccination campaigns, and if anyone would be able to speak about kind of the history of vaccine campaigns for pandemics on a global scale.
Or maybe I'll kick that off as the historian of medicine by training earlier in my career. It's good to be with everyone. Thank you for our organizers for organizing this event and for our students joining us either live or on the recording. And it's great to be here with Professor Faden and Professor Omer to talk about these topics that they have been so directly connected with here in the global COVID vaccine effort for months and months. So just a little bit about the historical context, which I am asked about often in terms of, what can we compare this experience of the vaccination program that we're living through today here in Connecticut, around the United States and around the world too, in terms of historical precursors. And the short answer is not much, right? We have not great examples to draw upon such a concentrated, concerted, massive effort to organize a global vaccination campaign against a novel pathogen at the scale and speed at which we're seeing right now. We have some examples we can draw upon of certainly global coordination of vaccination efforts when we think about smallpox and the eradication campaign of the 60s and 70s in particular. We can think about global health threats for which vaccines have been seen as a critical component. We can think about childhood vaccination campaigns where there is a coordinated, globally organized effort to deliver recommended childhood vaccines to children in low and middle income countries. But when we put all those elements together and we think about how significant the scientific implementation policy ethical hill is that we need to address, and we are working to address with the vaccine campaign, it doesn't give us a lot of playbooks to draw upon. We've heard those analogies about the airplane being built in mid-flight when we think about just the US vaccine effort and the challenges that it's faced. And as I think you'll hear throughout the evening tonight, the global effort is even that much more of a challenge, and frankly, that much closer to the ground if we're going to extend that airline metaphor. So we have some fragments of historical precedents to draw upon, but really we are in uncharted waters is what I would suggest.
Thank you. So thank you so much for this answer. I think I would like to push the discussion in a slightly different direction, but along the same lines, with regards to the COVID-19 pandemic. And we often talk about herd immunity being portrayed as like the goal that we'd like to achieve on a global scale. But the question is that actually something we're working towards at this point in time? I think we're also curious to know what is the current global goal if that's not the goal. And then also COVAX is a plan that exists, and we would love to hear more about what this is and the inequity in funding for it.
So, want to take the first vote on that one?
Sorry?
I was going to say, why don't you take the global public health goal, and then maybe I can say something about COVAX, or we both could, just what that went on.
So there are sort of various approaches to deal with the pandemic. One is the more direct approach, which is to say that, well, direct is a relative term. One is an approach where you say that you're going to control the infection because it's the infection that is responsible for all the bad things happening. You go after populations that are transmitting it more, and you target reduction of infection and ultimate achievement of herd immunity as your primary public health goal. Another way of looking at it is to say that to go after the people, not go after the people, you're going in benefit of the people, but to go after the infection in a way, go after the disease rather than the infection. And so the impact of infection on hospitalization, on severe disease, and especially on death more directly. So there you prioritize and focus on people who are dying of this disease and in disproportionate numbers and are being hospitalized and have long-term sequelae. And so at the global level and domestically, when these efforts started, and at different levels, all three of us have had the opportunity to look at this issue and contribute. The consensus has been that when you have limited supply, overall you do a hybrid approach, but you have a phased approach. So you go and target mortality and have a mortality first approach by targeting populations that are the highest risk of dying. And there were several reasons for that. First of all, death is irreversible. We are coming to a commemoration of an event that a lot of people believe is an exception to that rule, but that's a theological discussion. But overall, for the rest of us, death is irreversible. So that's one part, and the fact that there's social consensus on going after mortality. So that's why a lot of these overall approach has been to go after mortality first, but then not exclusively so. As your vaccine supply becomes available, as you have enough vaccine that you can interrupt transmission, as you accumulate the evidence of interrupting transmission and reduction in infection, you go for mass coverage. So that's what the goal has been. But here's the problem in terms of equity. The COVAX facility, and Professor Faden can certainly expand on that, but sure. The goal has been, this is a sort of an entity that is striving to vaccinate, especially low and middle income countries, based on what resources were available and what was possible. Their target is 20% of each country's population. That's not going to achieve interruption of transmission. And so the best hope is to prioritize those who are the most sick or can get the most sick after they get infected and are at high risk of dying. And so that's where equity becomes problematic, even more so that you are, in certain countries, you're able to not only reduce mortality, but interrupt transmission. And in COVAX countries, under the best circumstances, the rosiest scenarios do not let you interrupt transmission.
Yeah. So is that okay, Ken, if I just sort of come right in?
Sure.
Okay.
Sorry.
So let's spend a couple minutes sort of unpacking COVAX, but to just build on the very important point that Saad made from a global equity perspective, there are lots of ways to think about the dilemmas we're facing, but one way to think about it is that in a few, like 6 or 7 wealthy regions of the world, countries are getting closer to vaccinating most of their highest risk groups, right? So in the UK, I have to look at the statistic, but it's something like 70 or 80% of their elderly people have been vaccinated. In Israel, it's similarly. In Chile, in the US, in Japan, Europe is lagging behind. But these are all countries that will, in the reasonable near term, have accomplished what Saad was describing as the first public health strategy when you're in the acute phase of a pandemic with a pathogen that is very lethal, that actually does produce a significant amount of death. While low and middle income countries don't have, many of them, and certainly many low income countries don't have nearly enough to even begin to make a dent, right, in protecting their highest risk groups. So we're going to move on, as you hear in the US, shortly anybody over 16 is going to be able to get a vaccine in the US. And that's a wonderful thing from the US perspective. But if you're thinking about what it's like to be in a country that has not yet seen a single vaccine distributed, or has seen, you know, maybe enough for 1-2% of their population, it's a gut punch, right? It's really seriously problematic, and it's a tough issue. How to think about it, because on the one hand, we want to vaccinate everybody in the U.S., right? We want to make sure that our kids can go back to school in the fall. We want our lives back. Basically, we want our lives back, whatever the new normal is. In terms of Jason's point about not having a historical sort of precedent that we could just walk right into that playbook, in part we've had failures, right, in the past is a way to look at it. So with H1N1, which was a big flu scare, right, there was a state of affairs basically globally where the wealthy countries made sure there was enough vaccine for everyone in their countries. And by the time there was attention paid basically to sharing that precious resource, the vaccine, the pandemic had kind of played itself out, and Saad and Jason can fill out the details of that. And with the Ebola outbreaks that occurred more recently, there was also a sense of failure. The COVAX, which is part, as Saad has said, of the ACT Accelerator, was stood up basically in a kind of never again response to this. We're not going to do this again, right? We're not going to allow a global state of affairs where by the time vaccine is available for low and middle income countries, the pandemic is over. Like, that's not going to happen again. That was the spirit behind this strange animal that has been set up. We can't call it an entity or an organization. It's like a coalition or a consortium that has three big partners. One of the big partners is an organization that Saad can describe really well, that Jason was mentioning in terms of the concerted global effort to vaccinate children in low and in some cases middle income countries with basic childhood immunizations. It's an organization called Gavi that had its roots there. Another is an organization called CEPI, Coalition for Epidemic Preparedness Innovation, which I often get wrong, but got right this time. Okay, CEPI was stood up in response to the disaster of Ebola, basically, and saying we're not ever again going to be caught so flat-footed on the science. So they're an R&D group. Gavi was a sort of on the ground, how do we get vaccine, how do we fund and get vaccines, particularly to children, but not only to children in low-income countries. And then the WHO, which is in the business of being the WHO. So those three organizations have formed this consortium, to the goal of which is global equity. It was designed with global equity in its kind of defining mission statement, I guess. We are so far away from global equity with respect to vaccine distribution. It's not even sort of, it's like a kind of gleam in the eye, you know, aspirational thing. But we're way better than we were with respect to H1N1. There is vaccine now being distributed in low and middle income countries. That's not nothing. I mean, that's like a big step compared to where we were with the last sort of bite at this apple, which was nowhere near as big a bite and nowhere near as sour an apple, if we're going to torture the metaphor.
I'll just add just one point before we move to the next question, very briefly, just to tease out and sort of add some local data to that contrast, that stark disparity that Ruth referred to in terms of where we are in vaccination in countries like the United States compared to the global effort. Here in Connecticut, Ruth, you may not know, here in Connecticut is today the day we've opened to ages 16 and above, open eligibility. So many of our students, I've been talking to my advisees today, were reloading web pages at 12:01 a.m. or scheduled for appointments next week. And I suspect that may apply to some who are watching and participating here and today. And here in Connecticut, to Professor Faden's point, we've now, as of 4 o'clock today, we've administered 1.9 million doses in Connecticut, and 81% of our 65 plus population here in Connecticut, 81% has received one dose, 43% of the overall population. So we have really hit, you know, the kinds of targets that would be foreseen for that highest risk group and moving down moving down the priority groups to now where we stand. So that, I mean, really teases out where we are, and other states are in similar positions. You know, Connecticut's doing quite well, but the US story is broadly similar to that, and incredibly night and day from the global story that we're hearing and thinking about in terms of where we are and where we have to go. Saad, you're muted. Oh.
Yeah, I was going to mind my way through this. If if I can add to that, sort of a personal note to it, Ruth and I are part of the WHO working group on COVID-19 vaccines. And before a lot of these discussions were happening, in terms of now it's thought of it as a given that a mortality first approach will be there. And in retrospect, it does sound like counterintuitive, but it sounds very intuitive. So with that work and the National Academy's work that was done here, but around WHO, when you have to bring together values, people's values and aspirations from all around the world, it wasn't a given. We started with a clean slate. We had multiple levels of prioritization. We had academic work that was counter to the proposal that had strong emphasis on vaccinating the young first. And it wasn't that it was outlandish. It was based on very smart reasoning, but from our perspective, or at least from my perspective, it missed the point of tailoring ethics to the epidemiology of the disease. And the big glaring thing that we had facing us is that people at certain age groups and certain risk factors were not just like 2% or 50% or 80% higher at a 80% higher risk. They were like, we were dealing with 45-fold, 80-fold higher mortality based on the risk group. So in that situation, we, that's why sort of focusing on a mortality first strategy, that's where how we converged. It wasn't a given that we would have gotten that. And when we wrote this, you may remember that, Ruth, that when we wrote this, we said that this is not the last word on any prioritization. When there is a next pandemic, for example, if it acts like the 1918 flu, where the young are more impacted based on some immune factors in terms of how the immune system responds at various age levels, we would be the first ones to say, vaccinate this group first. The principles match with the epidemiology, and that's how you produce public health strategy.
And something that really needs to be underscored. So someday we'll write that story, Saad. Someday we'll write that story too. But is that what it means to be old is different in different parts of the world, and travels, of course, with deprivation and disadvantage. So from the standpoint of the WHO, that's not like the US. Saad was also on the National Academy's very important panel, and you can talk meaningfully and look at cutoffs at 60 or 65 or 70. One of the things that we were doing was looking at how the epidemic was disproportionately affecting mortality rates by ages that cut way, way sooner. So you lower into all of this that for some countries in the world, it's 50, right? It's not 65 or 70 where you start to see an increased mortality with age. And we have the same equity issues within the US, and we have written about this. If you stay within the US, some of you geeks, maybe not everybody is the kind of geek that Jason and Sada and I are in terms of hanging like on every vaccine twist and turn. But early days when vaccine was first available in the US, an advisory committee to the Centers for Disease Control recommended that the cutoff be 75, age 75. And the problem with that, I can like a pop quiz for those of you who are listening and watching. If you target people who are over 70 or over 75 in the US, what demographic are you disproportionately going to get and or miss in terms of deaths? What would you expect the life expectancy is of white people relative to African American people or Latinx people? It's lower, right? The average life expectancy for people who are Latinx background or African American or Native American or Alaskan Native is way shorter. So the deaths that happen in those communities happen earlier, right? Mostly the deaths that, and every death that you save is really, I mean, every death that you avert is really, really important. Obviously, we're not suggesting that a death of a white person is less important than the death of a Black person or vice versa, or the death of an American compared to a death of somebody who lives in Cambodia. But the point is, we have to be sensitive to the fact that the world, we started this pandemic in a world where the background conditions were already profoundly unjust, globally and within countries. So you then have to figure out, you're playing catch up right from the beginning, right? So before the pandemic even enters the scene, you're dealing with profound inequities in health and in quality of life more generally. You throw in the pandemic, everything gets exposed and exacerbated. And here we've got layered on top of that, all the geopolitics, all the differentials in global power, soft and hard, economic and otherwise, between wealthy countries and poor countries that also pre-exist, that are also profoundly at their roots, largely unjust. And you've got a toxic mix. You know, what we have now is, you know, not surprising.
Yeah, so thank you for outlining all of that. It's really illuminating, I think. And so you guys kind of already touched on this about barriers to equitable vaccine access. But maybe more specifically, or if you have others, we would want to know how infrastructure and funding have affected distribution efforts, because obviously that's very disparate on the global scale.
All right, so I'll take a deep breath before I start, because this makes me angry.
Yeah.
It makes me angry because we as a global community are letting this happen. We are in a condition of extreme inequity. And we are in a situation where the best case scenario, which is the COVAX facility, doesn't even aspire to go beyond 20%. And it's not for them. They are doing a heroic job. And we know several of those people who are involved personally, and they are working hard day in and day out. It's just that they cannot print money. They cannot have agreements. And I'll tell you what happened a little bit in terms of time. So pandemics and all epidemics are, their severity and their effectiveness that respond is a direct function of time. The earlier you intervene, the more effective you are. That is the case in terms of vaccine availability as well. So over the summer, so the COVAX was created in spring, late spring, and it crystallized in early summer in terms of in a concrete entity. And then it came to our committee to say, and others to say what happens within country. And there was another committee that said what happens between countries in terms of distribution. But the problem there was that when these things are, it's iterative, because people don't start with aspirations that are unrealistic. So the groups, when these discussions were happening, the US, the big players were missing in action. Not just missing in action, were antagonistic to the multilateral system, let alone an each a single entity like that. So when that happens, you don't even ask for the money. If you have zero and you're asking for $6 billion, that's $6 billion that you don't have. And so that's how much they asked for in terms of what the goal of the program was. In that milieu, because of the money that was absent and promise of those resources that were absent for 7 months, and now even the Biden administration has said, look, we are going to put $2 billion on the table, and this year and $2 billion next year. And then we'll ask the Europeans to put in more money. The Europeans put in some money before the US did, but it's not nearly enough. It may end up being enough for their ask, but the ask in the first place is modest. And in the time, even if they receive $15, $20 billion now, we have already passed that time when capacity has been booked by bilateral deals, when factories that could have been built haven't been built in the past 7 months, or contract manufacturing that was supposed to happen hasn't happened. So we have lost time in this pandemic because of policy inaction. And I'll give you, so a billion here, a billion there to an academic doesn't sound real, because it is a theoretical entity, quantity for most of us. If you looked at our pay slips, you would say that it is a big fantasy in terms of those numbers. But to come back to a serious point, just to give you a context, that the 614 billionaires that live in the US had an increase, not, everyone is, the whole thing was that the business is suffering and everything. They had an increase in their net worth of up to more than $925 billion between March and December 2020. So it may very well have well exceeded $1 trillion of just the billionaires living in the US. They weren't poor in March of 2020. And so when we are talking about sort of close to $1 trillion with 614 individuals in one country, albeit the richest country in the world, and then when the rest of the world is asking for, the world didn't even dare to ask for more than a relatively modest amount of money. So that's why I have to drink a glass of water when I start thinking about the enormous level of preventable inequity in vaccine distribution. So yes, there are a lot of things that are structural, that are ingrained, but this part of it was preventable. This part of it, we could have thrown money at it. And as a taxpayer in this country, but also as a scientist who works around the world, I can tell you that would have had a high return on investment.
Yeah. I mean, Saad has expressed this so compellingly, and he's 100% right. Right now, there are figures being thrown around that COVAX needs another $27 to $30 billion to go beyond the 20% and to start to make a dent into 2022 and 2023. So there's the money that needs to be raised. And, it is the case that for most of us, we can't even, millions are as far as I can think, right? Billions throw me off, right? And trillions are completely, crazy making. But we have passed trillions of dollars of COVID relief, all of which I'm supportive of in the US. But just to put this in perspective, as have the countries of Europe, Japan, Canada, the UK, people in wealthy countries are throwing tons of money appropriately at the problem overall for COVID. Against that backdrop, we could have thrown a lot more money a lot earlier. It's not only the fact, though, that the money wasn't put up in the beginning, it was the way in which, so that's a huge problem. Then you have high income countries, basically a metaphor that's been used a lot is they went into the store, the vaccine store, and they cleared the shelves of product. It's like a toilet paper thing in a snowstorm, right? Or the early days of the pandemic. And they went in and they cleared the shelves, right? Before COVAX, let alone middle income countries, many of them were even allowed to go shopping, right? And where COVAX had sort of preliminary contracts or was in the middle of contracting, the wealthy countries of the world would step in front, right? And delay the fulfillment or the finalization of the contracts with this entity that was set up to deal with global equity. Now, at the same time, we have to appreciate that these countries are under tremendous pressure, right? Politically and humanly. And especially the US, at the time when the US is doing all of the sort of cementing of many-fold more doses of vaccine than the country could possibly use, we're having this remarkably horrible death rate, right? And we're having more dead Americans than many of the countries of the world combined. So it's a complicated political and human picture and complicated ethics picture, but it didn't have to be this way. We could have done what we needed to do in terms of the use, the needs domestically, and done a lot better. So now the question is, what should we do now, right? Besides planning for the next pandemic and trying to, have a building on COVAX and the ACT Accelerator to something better, like what should we do now? And I'm going to stop talking and let my colleagues address what can we do right now, right? Besides throwing more money, which we need to do. We, the wealthy countries.
So I don't know, Jason, if you want to add to that, I have a few thoughts about that beyond the money. I think beyond the money. So here's the thing. No matter what we say, the world has unequal political power, and rich and powerful countries are at their best when they use that unequal power to everyone's benefit. And it has happened. It's not just an aspiration. So PEPFAR for HIV/AIDS and several other initiatives are an example of that. And so what needs to happen is an engagement by the US and some of the major players on the next phase, not just in terms of money, in terms of intellectual property and other threats. So one of the things that we don't, so it's easier to vent at the most powerful kid on the block, and which we all did right now. But on the other hand, one of the biggest immediate threat to global equity is coming from the Indian government. India has built up a really stellar vaccine industry. And the biggest manufacturer by volume in the world is the Serum Institute of India. And they produce good, high quality vaccines. And therefore, it was very natural for COVAX and other major players to say that we're going to take the Oxford vaccine and give transfer the technology earlier on, even before it is approved, to the Serum Institute of India. So therefore, their cost per dose is low, and they can manufacture en masse, and we will spread it around the world. Guess what happened? The Indian government imposed export restrictions, and that really undercut. We all completely understand that there's a raging outbreak in India itself, and so it's not an easy decision for any government. But on the other hand, we need to have then systems where there are multiple countries producing this. So equity will require building up those systems so they are not vulnerable to just stopping that. Why is Malawi not getting the doses that they were promised, that they paid for sometimes in some cases, and in certain cases it was through donations. But in any case, they were relying on these kinds of supplies, and that undercuts a lot of national strategies.
Mm-hmm. I mean, so that's so important. And when we think to the future for the next pandemic, we probably, some of you are familiar with the term food sovereignty, and the notion that countries are concerned about having, it's a contested term, but the idea being that countries want to have sufficient control over their food supply so that they're not essentially completely dependent on other countries who can then choke them, through leverage and other sorts of things. So the notion of regional vaccine sovereignty is increasingly important, that different regions of the world are positioned to be able to produce vaccines that they need for their local regions. May not be, each country can't have the production facility, but regions of the world could have, and in a decentralized way with a plan, so that, lots of things like that are really important. Another near-term conversation is dose redistribution or dose sharing. This is the argument that has come out. The Pope has come out with this. The Director General of the WHO and with a committee has come out with this. The Wellcome, a big charity, has come out with a position paper. The idea behind dose sharing is just what it sounds like. If countries have, as the US has, as Canada has, as the EU has, as the UK has, as Japan has, as Australia has, under contract in one way or another, many-fold more vaccine doses than they need to vaccine vaccinate or immunize their entire populations. And there are reasons why countries did that. I mean, we can go into that later. It wasn't like a crazy position. Now is the time, so it's argued, that countries should start loosening up some of that and start sharing with, ideally with COVAX, so that COVAX can redistribute using its central sort of mechanism. But some countries are doing it bilaterally for soft diplomacy reasons. So you may have heard that the US has lent, so the term is, some of its vaccine to Canada and to Mexico. I don't think they're really expecting Mexico and Canada to pay them back, but send them back doses. But that's the argument, and that was obviously strategic in terms of the alliance between the North American countries. But there's sort of pragmatic issues as well, and I will defer to Saad and also Jason on this. But it's possible that some of the vaccine that we're going to have on stockpile or that we're holding on to will not help us in the future, right? They may be against the wrong variants, right? They could be really useful right now if they were deployed right now elsewhere in the world, but it's not clear that holding on to them for 2022 or 2023 is really gonna be ideal, right? So there are prudential issues as well. It's like, okay, maybe we can work some deals and move some of this vaccine, some of which exists and some of which is under contract, or at least, they don't, it's not like there are, tons of it, but there's one estimate out of Wellcome, this big charity in the UK, that if just the countries I enumerated were to shake loose all of their quote excess vaccine, there'd be 1 billion doses tomorrow that could be shipped to COVAX. And given that COVAX has something like 2 point something billion altogether, that would be a real infusion. Now, even if that's off by half, even if it's only 500 million doses, that's still a lot. That's a substantial increase in the amount of vaccine available for COVAX to distribute. So there's that. There's also all the stuff that I'm not expert in that has to do with tech transfer and licensing agreements and intellectual property, much disputed right now, much debated, but there's got to be some way to fix that issue. I understand why companies, particularly companies like Moderna and Pfizer that have these new wonderful platforms and technologies, are leery, but there are ways to do this, I am sure, and it's possible to stand up the production capacity. So it's a lot of things that could be done in the there are a few things that could be done in the near term, and there's a lot to be done in the planning for the next pandemic.
I'll just add just one point or two, and then really a question building off of something Saad said a moment ago. I'd love to pick my colleagues' brains while they're here, given all the thought they've put into the global vaccine story, more so than I have over the most recent months. Absolutely, I've been worried to see those statements, even from the US government right now, talking about the millions of vaccine doses that we have, including millions of doses of the AstraZeneca vaccine, right? That we are continuing to manufacture to fulfill those orders, a vaccine that has not been authorized or used in the United States, and the role that it will play in our vaccination effort here in the US is at best a question mark, given where we are and the number of doses and the authorized vaccines we have. And the statement from the US for all of its vaccines is saying we want to keep these doses, at least for now, except for the small loans to Canada and Mexico as insurance policies of sorts, given the fact that there are more chapters to be written potentially in terms of how we use these vaccines. But I think Ruth's point is right on about whether or not the vaccines that we are currently holding on to and stockpiling right now will be the tools that we may need if we need more vaccine doses in the future. But I did want to ask, while we have Ruth and Saad here, I have been following the AstraZeneca story around the world, and I've been terrified by it because I've heard how important, right, the AstraZeneca vaccine appears to be to this global vaccination effort in terms of the commitments that have been made, in terms of the role that it is intended to play really as the centerpiece of the global vaccine effort. And those of you who haven't been following the twists and turns of the AstraZeneca vaccine story, there's too many to count, but there have been a number of concerns and questions and issues in various European and Canadian contexts where the vaccine has been cautioned against, suspended temporarily, suspended for some groups, twists and turns galore. And I worry that what's already a very discouraging present state of affairs could be that much worse if the AstraZeneca vaccine fails to serve the role that even right now it's planning on it's intended to serve. So I wondered, Saad and Ruth, are my concerns overblown, or is this another sort of challenge, another hill to climb in this already really substantial effort?
So you're concerned about the effectiveness of?
Yeah, I mean, is the AstraZeneca vaccine, and what if we can't count on it? What if it turns out to be rejected globally, or the fact that if high income countries stop using it? We've seen stories in terms of lower income countries like Rhoda rejecting vaccines. I worry about the fact that we might even lose this important component that we're counting on even right now.
I think if I may, Ruth, unless you want to start.
Please, go ahead, I'll follow on.
Yeah, so I think you're right. It's a lot of it is perception. A lot of it is communication, and there have been a ton of unforced errors, starting with projecting sort of confidence when it wasn't warranted, meaning that the AstraZeneca Oxford vaccine would be available in August. Those were the statements coming out initially over spring, etc. To a few other unforced errors. But if you peel that off, it's a good vaccine. It's a solid vaccine, and there is a race against time. It will be if we deploy this. So this is, again, in the pandemics and epidemics and outbreaks are not static phenomena. It's a time bound. So what is effective now may not be effective later. So I can imagine a scenario when, so the main argument for hoarding these vaccines is, first of all, unexpected disruption in projected supply. That's a reasonable one. The other one is that what if we need a booster later, in terms of to enhance immunity due to the variants. So here's the problem. It is more likely the next best use of the best use of the next dose for an AstraZeneca vaccine, and we have a medical model overall, not by vaccine type, is actually to go out and tamp that outbreak now elsewhere so that those variants do not emerge.
Exactly.
So it's not like a sort of a safety deposit box where, the value of your gold grows. The value of your vaccine is not going to grow if there are variants that paradoxically then render these vaccines not that useful. So the time to actually think about releasing some of those doses, especially for AstraZeneca, which has already been approved in a lot of countries. And there are countries, so the alternative, a lot of countries they're using the Chinese and the Russian vaccines that have gone through less testing and less country level experience. Like this vaccine has been used in the UK fairly successfully. I think, often with the safety events, when they emerge, the end result is a precaution that you have in terms of administration, etc. It's very rare that you discontinue the vaccine altogether. But it may lose its utility if you let these variants emerge because the outbreak is so rampant. Yeah. So I think it requires political courage. It requires maturity, and it requires people in high-income countries asking for and demanding that a smart strategy. A lot of times, governments are scared of a scenario where they've sent the vaccines overseas and then they get political pushback domestically. And so I think that's what the general public can do, is to make sure that they provide that room for governments to act ethically.
It's a really complicated state of affairs. And I don't know how many people that are with us, again, are the kind of nerds that have followed all the twists and turns with the AstraZeneca vaccine. But it's almost ironic. It started out with there is, as Saad has said, as Tony Fauci first, I think, coined it, right? A lot of unforced errors with this vaccine. But a nearish term issue was that there was not very much data about the vaccine and its effectiveness in older people at the time that it was coming up for authorization. The UK made a bet that it was. The WHO made a bet that it was going to be effective in older people for reasons that Saad can unpack better than I can, but having to do with other indicators that would suggest that it should perform the right way, and because other vaccines were similarly doing okay in older people, if somewhat less effective. But some European countries said no in the beginning, initially. For a few days, they said, no, we're not going to use this vaccine with older people. And then these European countries reversed themselves. Recently, there has been a concern about an association with a very unusual kind of thromboembolic event that is occurring. One, it has occurred in Europe, especially in Germany, where it's been the most carefully evaluated, is occurring in younger people and especially in younger women. So now we have Canada and any number of European countries saying the vaccine that they were afraid to use with older people, they are now only going to use with people who are over 55 or 60. This may be taken back again. We don't know. But the point is there is this ping-pongy thing going on. Without commenting on whether that's the right public health policy or not, the dynamic is that there is sort of conversation about whether this vaccine is good enough, right, for use in wealthy countries that have options. At the same time that it is the workhorse, which is where Jason was worried, right? It is the workhorse, at least for right now. It won't always be, but it's the workhorse vaccine, the dominant vaccine in the COVAX supply chain at the moment. There will be others, right? And Saad's view that he expressed is, I think, the consensus view. On balance, this is a really good vaccine, and whether there may end up being some subpopulations that shouldn't get the vaccine or not, on balance, it's a really good vaccine in a context where the pandemic really needs good vaccines to be distributed in countries that are not as fortunate as the US to have all these other vaccine options, right? Or Europe that has options. So the question comes up, how's it going to work, like globally, if wealthy countries are going to say, we're going to limit our use of this vaccine so you can have our extra, right? And then the political leaders of the countries that are getting the really good vaccine, right? It's still a really good vaccine, have to answer to their public who says, wait a minute, we're taking the leftovers, we're taking the vaccines that the Americans did want to give to their own people. Now, we're not at that stage yet, but it's going to be really important to avoid, right, a describing of the AstraZeneca vaccine as somehow not a good vaccine unless we really come to conclude, that is, say, the experts like Saad, the sort of epidemiologists and the virologists and the vaccine public health specialists conclude that it isn't, right? But right now, the regulators are still saying, on balance, at a population level, this is a vaccine that should be used, right? And we have to, that seems like the right view right now. So more about AstraZeneca than probably you all care about, but it ties up to the geopolitics and the global equity issues, right? There's not going to be enough of the mRNA vaccines available soon enough to be able to fill that gap at the global level, I don't think. Saad, what do you think?
I agree, but I think we need the more the merrier out there.
Yeah.
I think there should be a serious discussion of more robust studies and trials of the Russian vaccine, the Chinese vaccines. There, the gap is in terms of those data. The better, the more robust the marketplace is of various products, the more options countries have, more high quality options countries have.
Okay. Keeping an eye on time, I think you have space for one more set of questions. Just really briefly, or not so briefly, how would you evaluate our current global vaccination efforts? I would really like, most of us are students and we would love a grade. And also, we would love to hear thoughts on the next best steps forward, just not only for the pandemic that we're currently in, but also for this pandemics that are hopefully very far away, but eventually coming.
Are we looking for grade inflation, or is Yale a university that holds fast against grade inflation? Just asking.
We think we hold fast against great inflation.
I don't think I have a comment for our great inflation.
Oh my.
Jason, do you want to go first?
Sure. I mean, I don't suspect you're going to get a lot of high grades from any of us, as the tenor of the conversation has suggested in terms of where we are, to put it mildly. Let me. So I'm going to punt on that first one, because I think we've covered so much of the failing performance so far in terms of the global community. Let me take that more hopeful, forward-looking view, perhaps. Not that there's not a tremendous amount of work still to be done in the months and quite frankly years ahead with this immediate pandemic, but I sure hope that this will help us yet again sort of return our attention to the importance of a coordinated, truly global effort to global health, and to recognize the need for the empowered global health organizations, including an empowered, supported, adequately funded World Health Organization that has been desperately starved of funds throughout its history, by the countries that support it, right? By the members, the global community, by what they have allocated to the World Health Organization, what they have charged it to do, and every time there's an epidemic or a pandemic, Ebola was the example. Not we all, but the global community says, well, why did the World Health Organization drop the ball? And not that they're perfect by any stretch, but the resources and the design that they've been given vastly pales in comparison to what role they could play as a democratic global coordinating body to help us in all of these aspects of preparedness, response, and activities that thankfully in complement, or perhaps in response, we've gotten organizations like Gavi and CEPI and organizations supported by the global community, philanthropic organizations, the Gates Foundation, and others that have helped in some sense to fill, I don't want to call it a void, but to fill the needs that are clearly there. And I just hope that, that we will, not that we're at the moment of being able to take a step back and think about, how we can equip ourselves for the next one, but that will help us all and our global leaders, particularly in high-income countries, to recognize the need for a far greater sustained, enduring investment to our efforts to promote global health. So I'm hopeful. Am I optimistic that it will happen? Well, no, that's another story, but I'm hopeful that this might be a moment where we might make progress that we haven't made in past health emergencies, past health crises. And I hope that's something we can see going forward as the vaccination effort and the broader efforts continue.
You want me to go next, Saad? You
Sure.
can close us out. Okay. So on the grade question, if we graded on a historical curve, right? If that were possible, then I would say that we're about 25 times better than we were with H1N1, maybe more, right? So if that was, but then you have to have kind of a log scale. I'm not sure how to do this. Like that was a flat out F, maybe this is like a D. Or an F2, I'm not sure, but it's better. See, the problem is I don't have a floor. Like, I don't know what to do with H1N1 because that was so awful, right? It just turned out it wasn't that bad a pandemic, but it was so awful. This is better. So if they're both Fs, I've got a problem. So that's I'm running out of low grades. There's not enough, even with pluses and, and minuses, like, that was an F minus and this is like an F plus. I don't know, something like that, or an E. Now maybe F to like D minus or something. Hopeful, I think this is, I'm just lay this out. I, in my most optimistic moment, I think that there may be a global learning here that not only prepares for a better response to the next pandemic, but also maybe helps with climate change as well. Both of these are, let's not use the overworked existential, but they are extraordinary threats to human experience. And they cannot be really satisfactorily managed except globally. There are others as well, but these are the two massive ones. We've just had an extraordinary experience where the failure on the part of the world to function collectively, effectively with what is essentially an indivisible collective action problem, right? Hopefully people will have seen what it cost in terms of people's lives and treasure and just anguish. And maybe that will galvanize not only in terms of getting a global structure in place for pandemic planning, but maybe also realize that whatever can be done there, maybe that will help us do something better with climate change as well.
So just to end, to sort of conclude this conversation, I'm a little bit if I were to break it down, I think in terms of science, the world community got a pretty decent A, maybe even in A plus for certain technologies. In terms of delivery and ethics and equity, we haven't done so far. So it's the second and third assignment is an F and a D. Overall, semester grade is an incomplete because it's not irredeemable. We can redeem ourselves.
I like that.
And so you can do extra assignment, like and the world can do an extra assignment to make up for a lot of the bad performance in a couple of current assignments. I would say the other thing I would say is in terms of the future, look, these are multi-generational events. Our generation didn't do as well as we should have, and that's a fact. And the way we can begin to redress that is by making sure, especially those of us who are in the academia, pass on that memory, that knowledge, to build a better ethos, that there are certain things just unacceptable, that you let 500,000 of your countrymen die on your watch, irrespective of which political party, which ideological tribe you belong to. This should be unacceptable. That you have a rolling disaster unfolding in low and middle income countries right now in front of us, and that's not headline news. So I hope we do a better job of transferring that memory, transferring those lessons, because that's all we can do. And because educational institutions survive, everything else humans build. So if you think about it, the top 10 corporations that were there in 1701, when our little university was founded, are nowhere to be found. WHO will evolve and dissolve into some other entity. There is some set of longevity to educational institutions. So this 300-year-old institution has survived. And that's why it is a unique responsibility to those of us who have old and new links to this institution to keep that memory alive, to make sure that these lessons are transferred from generation to generation, so that the next time this big one happens, we can have at least a decent B, if not a failing grade from 2 out of 3 professors, and the most generous of the assessment is an incomplete grade.
Alrighty, that is all the time we have for this evening. I just want to say thank you so much for our speakers, for your time and your amazing insights and sharing your knowledge with us. Also like to thank our audience. Thank you for coming and learning with us. It's been a wonderful time. Closing statements wise, this is a workshop that is being recorded, and once we have the link available, we will put that on the Facebook event page, so stay tuned. And if you haven't already, please go like our page on Facebook, and we have an Instagram too, Shay at Yale. Go ahead and give us a like there too. I think that's it. Thank you so much for everyone for coming.
Hi everyone. Bye-bye. Thank you. Bye guys.
Bye.